Hello class, today I'll be giving a presentation on the thigh thrust and evidence-based approach. So we'll start off by going over a background on the thigh thrust, followed by indications for its use, how to perform the test, statistical analysis, and at the end we'll have a video demonstration followed by a class demonstration and some time to practice. So first I want to start off by giving a background on the thigh thrust. The SI joint is a frequent source of low back pain as well as referred leg pain, being an indicated pain source in up to 30% of patients with chronic low back pain. And it can be difficult to determine which SI tests to use to identify SI joint pain as well as dysfunction, as a universally accepted gold standard for diagnosing SI joint pain has yet to be established. Right now there are pain provocation tests, motion palpation tests, as well as tests to assess pelvic positions. The thigh thrust falls under that pain provocation test category and can be used to rule in SI joint as well as to help differentiate it from lumbar spine pain. As previously mentioned, low back pain is the main indication for the thigh thrust pain provocation exam to be performed. However, an article published by Dreyfus et al. Listed other indications for SI joint pain in which a pain provocation test such as the thigh thrust may be used, aside from low back pain, which were ankylosing spondylitis and postpartum pelvic pain. We are now going to discuss how to properly perform the thigh thrust. This test can also be referred to as the femoral or posterior shear test. In this test, the patient is placed in the supine position with the contralateral leg extended. The therapist stands alongside the patient, flexes the affected leg's hip and knee to 90 degrees, and places one hand cupping the sacrum. The therapist then applies force in the posterior direction through the femur, with a positive test being the reproduction or increase of pain in the SI joint region. So now onto the validity of the test. In a systematic review conducted by Stuber et al., the sensitivity, specificity, and positive and negative likelihood ratios were examined in 5 studies. The sensitivity in these 5 tests ranged from 36 to 88%. This shows the thigh thrust's ability to determine injury to the SI joint. The specificity within these 5 exams ranged from 50 to 100%. This shows the thigh thrust's ability to determine the absence of injury to the SI joint. These wide ranges found in the sensitivity and specificity show that further research may be needed. However, in Laslet's 2005 article included in the review, the thigh thrust was shown to have the highest sensitivity out of all the Laslet SI joint provocation tests, as well as the second highest specificity. In this systematic review, the positive likelihood ratios range from 0.78 to 2.8. which shows the frequency that the subjects who test positive will actually have the SI joint condition. A value between 2 to 5 is considered small, while values above 10 are considered conclusive. The negative likelihood ratios range from 0.18 to 1.22, showing the frequency in which those with a negative thigh thrust test that actually do not have the condition. With these, a value between 0.1 to 0.2 is considered moderate, while values below 0.1 are considered to be strong. Now, onto the reliability. In studies which looked at the inter-examiner reliability in both the left and right side of the patient found inter-examiner reliability of 0.40 to 0.74 on the left and 0.46 to 0.76 on the right, showing that this agreement was fair to moderate. In studies that did not specify right versus left, the inter-examiner values had moderate to substantial agreement with values of 0.64 to 0.88. The intra-examiner reliability found values of 0.40 on the left and 0.44 on the right, with intra-examiner reliability being the degree of agreement among repeated administrations of the thigh thrust performed by a single rater. These values show fair agreement. As far as recommendations, overall there were slight variations in how the thigh thrust was performed, with some studies not placing a hand under the sacrum prior to the posterior force being applied through the femur. According to current evidence, relying only on pain provocation tests used in isolation are not recommended to avoid overdiagnosis of SI joint pain. However, when selecting a cluster of SI joint tests to perform, the thigh thrust should be included due to its high sensitivity in recent research. Future research should look to standardize the value of minimum pain relief, which will allow for easier comparison between subjects as well as between studies, as definitions of positive response to SI joint injection range from 70 to 90% relief in order to meet inclusion criteria for various studies. Now, onto the demonstration. The therapist flexes the affected leg's hip and knee to 90 degrees, rotates the patient, and places one hand cupping the sacrum. The therapist then applies force in the posterior direction through the femur. This angle allows for a better view at the posterior force being applied through the femur. The patient's leg is then positioned back to the starting position once the thigh thrust is completed. This close-up angle allows for the viewer to better see the hand position when cupping the sacrum prior to the posterior force being applied. Once again, we are looking for pain provocation with this test. And that's it for the thigh thrust. Here are the references used for this presentation.